The risk factors have been revised in this guideline, and it's not the same as the previous, though it includes the same factors most of the time. The lower gestational age, it's very important. I mean, Professor Maisel's study has shown that even being born 37 and 38 weeks is a significant risk for jaundice. So every week that the baby is premature, the risk goes up significantly. And if the baby has any jaundice in the first 24 hours after birth, in this case, don't panic in most of the situations, but it's important to be alert and repeat at regular intervals. Treat according to the chart for that age and look for pathological factors. Here I would like to add that because of the delayed cord clamping becoming universal, jaundice, when you measure it, it's not visible jaundice in most of these babies, but when you measure it, you may start getting it in the phototherapy line. So following the trend should reassure you if there is no other risk factor. The pre-discharge transcutaneous bilirubin or total serum bilirubin approaching the phototherapy threshold is a risk factor. Hemolysis from any cause, if known or suspected, based on a rapid rise of bilirubin. So the rapid rise is defined as more than 0.3 milligram per deciliter per hour in the first 24 hours, or it's more than 0.2 milligram per deciliter per hour thereafter. So this part has changed from before. Phototherapy before discharge is a risk factor for further jaundice. If the parent or sibling required phototherapy or exchange transfusion, because the liver maturation and the other factors are usually in line in the family. Of course, the only exception is the breastfeeding gets better as a pregnancy. I mean, the number of pregnancies increases. So the risk is mainly in the primary gravida mother who is breastfeeding. Once she has successfully breastfed the baby, the subsequent pregnancies, it gets easier. The family history or genetic ancestry suggestive of inherited red blood cell disorder, including G6PD. So there is a lot of focus on G6PD deficiency because by the guideline, about 14% of the African American population is at risk of G6PD. And as we live in the Middle East and in Asian countries as well, North India, for example, G6PD is fairly common, same in China and certain populations. So we should be aware of the local incidence as well as the risk associated. If there is a sudden rise in jaundice in a day 3, day 4 baby where it is not expected, the previous screening was normal, you definitely have to think of G6PD deficiency. And remember that during the period of acute hemolysis, your level may not be confirmatory. So if you get a normal result because there are mainly the young RBCs, you may have to repeat it after 3 months if your suspicion was strong. Most of the setups like ours has G6PD in the newborn screening. So if the baby is exclusive breastfeeding with suboptimal intake, so this is defined by the weight gain in the first few days or the weight loss, and we need to do our best to support and encourage early expressing to avoid this rise in jaundice. If there is a scalp hematoma like cephalhematoma or significant bruising, that's a risk factor as well. Down syndrome itself is a risk because of the liver maturation and other factors. The babies usually have polycythemia as well. And if there is a macrosomic infant of diabetic mother, that's a risk as well. So the risk has become more, the definition of risk has become more comprehensive, and it covers most of the risk factors.